I'd like to use this lecture to share with you some of the things that we've been doing in the last few years. And Andrew, perhaps you will see that some of the things are a little bit different, okay? And certainly it will be very different from the last time when I spoke. And one of the things I want to talk about is the combination of nanotechnology and advanced instrumentation, especially photonic instrumentation, for image-guided precision medicine. Image-guided precision medicine primarily refers to image-guided diagnostics and therapy and surgery. Okay, so as I go on, hopefully you will pick up some of the interesting ideas. I think this area of new technology development for quantitative or precision medicine, especially like Professor Bashir's overview. I pick up a new word, is the engineering or technology development for quantitative medicine. But I would add quantitative and precision medicine, okay? Because quantitative is precise. Precise is quantitative, okay? And let me start to say, to describe the problem. Intraoperative, during surgery imaging, and precision surgery. One of the things in quantitative medicine or precision medicine want to do is this idea of precision surgery. Cancer surgery, cancer is still a major problem. It will be a problem for society, with us, in my opinion, for the next 100 years or even more. It is a major health a problem. And of course, other problems are cardiovascular, neurological, these kind of things. But one of the things we've been focused on is to develop new technologies for quantitative cancer studies. One of the things I've been worked with surgeons for the last 8 years, I have to say that I learned quite a bit, and mainly from the medical needs, the medical problem point of view. Some of the people say, my colleagues say, these surgeons make too much money and they are too arrogant. They don't want to work with us. No, that's not true. They're actually very eager to apply engineering technologies to their patient. But they want to be the first one. Okay? Especially they want to be the first one. They're very eager. They will go out of the way to apply new technologies to their patient. And I think that's their proud. That's their accomplishment. Okay? That's their job. So one of the things I learned is that the tumor margin is still a big problem. If you look at a pig lung, what you're looking at is a fresh, bloody pig lung. Okay? We know that there's a tumor because we implanted a tumor. But can you tell where the tumor is? No. Okay? And it's hard to identify where the tumor. And also, if you identify the tumor, you make a resection, you cut it surgically. How do you know you cut it entirely? Is anything residue left? Okay? And the other issue, the problem is that how do you know you have cut the lymph nodes? Whether the lymph nodes contains tumor cell. Okay? So I've worked with a number of cancer surgeons. After their surgery, the first thing they do is to meet the family. That's their happiest moment, is to meet the patient's family. I'll be waiting outside the door. But if you hear the surgeons during that thing, they always say, okay, the tumor is removed completely and the patient is cured. But as a matter of fact, 40% of the chances, statistically, there's still residue tumor left in the body, and that residue tumor going to come back as recurrence. Okay, on the other hand, can you imagine that a cancer surgeon would tell the family, oh, I'm sorry, I'm not sure 40%, and there's maybe a 40% chance the tumor is not cut out, so you should get ready to come back in about 1 to 2 years. They cannot say that, right? But the hard truth, the fact is that there is 40% probability the same cancer is going to reoccur and needs to do resection one more time. And that's a major problem, so we're trying to address that. The idea of trying to address actually is like this, okay? Here's a real human pancreatic cancer specimen. This patient being operated at Emory Hospital by one of our surgeons. I think we believe we saved his life. Okay? I'm not sure. I don't have the scientific evidence to follow up. Still too short. Okay? The idea is that the surgeon made a cut. Okay, this is the tumor. Okay, then that's the margin. That's where you cut it. Okay, that's where you cut it. Don't look at that piece yet. Okay, imagine that piece is still inside the patient's body. Okay, this is the piece is first being cut. Okay, then he immediately brought this sample to us, said, can you use your spectroscopy nanoparticles, look at it, whether this boundary is clean. When we look at it, wow, it's all kind of tumor cell, the optical signals all glowing. We said no. Then the surgeons are very action-oriented. In a way, they like engineers, they like to work on things. Without asking further questions, he went back into the room, cut another piece. That's the second piece cut. Okay? Surgeons are paid more because they have to make decisions very quickly. In a few minutes, they just have to do it, right? And then he brought another piece to us. Okay? This time, smaller piece. You look at it again. Then we look at the margin here. It's clean. It's perfect. It's clean. No problem. No more tumor cell. So if you look at this schematically, that's the first cut. And you cut here. See, that contains a lot of tumor. That would be the residual tumor left. Okay? If we had followed his standard procedure without our optical spectroscopy detection, he would stop right here with that piece left in the body. If that's the case, for sure, the patient is going to come back. The tumor is going to come back. Okay? Then he made another one. That's clean. The patient is still alive. Everything is fine. Okay? I don't have the scientific evidence. I think we made a difference. Okay? That's one of the things. The other thing that to broadly do this work, we developed an integrated multi-channel system for image-guided surgery. Okay, and that is pancreatic cancer. This is the clinical trial at Emory Hospital, and we're also doing another clinical trial for lung cancer at University of Pennsylvania. And this is specifically for the lung cancer because we're supported by this NIH Director's Transformative Award. I think it is transformative. Transformative award. The idea is that we build this multi-channel system. We have 4 channels, essentially. The first one is anatomic. Okay, just the color video. You look at the anatomy. And the second channel is that we have a near-infrared laser beam, very much like this laser pointer. Okay, but it's in the near-infrared because we want it to penetrate better blood and tissue. Okay, so optical scattering for light is always a problem. It's going to limit your penetration depth, but still in the near-infrared, the penetration is better than in the visible. And for that reason, the red light is always, it's called the red because the wavelength is red, because you can see better when it's fog, that kind of things. Okay? And the third channel is a near-infrared, either fluorescence or surface-enhanced Raman channel. It's coded in a pseudo color. This is not the real color because we can use a computer to code the near-infrared signal in any color we want. And the fourth channel is a spectroscopy one because we can analyze that kind of optical signal by a spectrometer, okay, and then disperse the signal versus wavelength. If you plot the intensity versus wavelength, that's called spectroscopy. Because if you do this one, you can subtract the background so well, you can tell the spectroscopic shape. I believe that when we do spectroscopy, we're able to detect just a few tumor cells in the body. Ultimately, academically, we want to do a single cell. Okay? You know, clinically, I'm not so sure, but academically, it's very intriguing if you're able to just detect, identify a single cancer cell. Not only cancer, maybe a stem cell or other kind of rare cell in the body by optical imaging. That's a very powerful concept that could open a lot of things. That's something I want to pursue, maybe another transformative. Who knows, right? I think it's transformative, able to detect and manipulate individual rare cell in the body through this kind of instrumentation. So then by computing software, okay, we combine all of the things. So that's the composite image. So the surgeon would see this in the screen, and he can identify or highlight the tumor here. You mark that region. Okay, so I think Irvine asked whether we have agent that can detect specific type of tumor. Well, my answer is that we actually want to several type of agents or contrast agent nanoparticles. One would able to broadly detect any tumor. The second would able to target some of the receptors, tell us what kind of tumor is it. And still a third one would able to highlight the nerves, because you don't really want to cut the nerves. Roger Chen, UC San Diego, he published a paper at PNAS. He identified some of these peptides able to bind to the nerves during surgery. And I haven't seen any follow-up paper yet by him. Obviously, I've heard that he got some really health problems. And even better, not only the nerve, some of the vital blood vessels, the arteries, if we can highlight that during surgery, that would be beneficial. So for that kind of application, you really need a multicolor, multiplexing strategy. Okay? So the opportunities, in my opinion, for engineering is really limitless. One of the key components that we've developed in the last few years is this handheld spectroscopic device, and we have a nickname we call Spectro pen. Essentially, it's very much like a pen-like kind of device with optical fiber. So the surgeon or your hands can hold it during surgery, scan through the cavity, the surgical surface. You look for any residue tumor or lymph nodes or anything that is suspicious, on the surface of the cut. Okay, so this actually overcomes the penetration problem, is because that during surgery you already cut it open. You're looking at the surface you already cut. Okay, so if there's any tumor cells, it's exposed. Okay, so you can ask that what happens if I have a tumor buried deeply behind the surface? Well, you're out of luck, almost out of luck, unless that tumor nodule is within about a centimeter in deep. Okay, it turned out that by using 785 nanometer, if a tumor is buried about a centimeter or so, we can still pick that up. That, I have to say, is a lot better than our eyes. Our eyes cannot even see a millimeter. Okay, if you look at a blood tissue, we don't know anything behind it. Okay, because the eye is based on visible signals. The near infrared is still a little bit better. There are some people claim that by using optical tomography, they can do as deep as 10 centimeter. Maybe, but the signal they get, the number of photons they get, is so small, they basically have to wait an entire month to get the image. Okay, Theoretically, yes, it's possible. In practice, you don't get enough throughput, enough signal intensity for you to do this in real time. So at this time, a centimeter is almost the limit we can penetrate into the tissue. Of course, you can look at another way, and inside this fiber optic paint device, the design is very simple. Just two fibers. One is to deliver the near-infrared laser beam. The other is to collect the signals and transmit that back to a spectrometer. So to initially design this, it cost us about $25,000. And now there's a company in China that can do this for $200. Essentially, make it disposable. It's a single use. It's like your razor blade. Because you don't want this one to touch one patient, then you transfer it to another patient, the contamination, the infection, okay? So essentially, this thing can be developed as a single use, okay? And the actual system is not too complicated. Essentially, if we start here, see, we deal with lung cancer. We put the patient here on the table. So that's the wide field, that's a lens. Look at the entire surgical field of view, and that's the spectroscopic paint device, let you do spectroscopy. And typically, we have two versions. One version is that we would intravenously inject the contrast agent into the patient after about 4 to 5 hours. Then you can put the patient on the table. Then the surgeon can look at the tumor. Or we have another version. The patient can drink the contrast agent in water in the morning. Tell you a little bit about that. And then you put the patient on the table and you illuminate that with this light source. The tumors would be emitting light. So it's really a very interesting idea. You design these agents to make the tumor glow in the dark, so to speak. Okay, so the tumor literally emitting light, and our goal of this is whether we can push the sensitivity and the specificity all the way to a single tumor cell in the body. That would be a science paper, I believe. Right? Maybe another science paper. And the first version, the prototype of this is this one. It's built by one of my former students, Michael Mancini, and he has moved on to start a company, and he's the VP for research of this company to commercialize this. But this looks, it's just the prototype, a laboratory prototype. With engineering design, with arts, that kind of thing, they can make this very appealing. So that's not my job anymore. My talent, I don't have the talent in the artistic design to make it, to curve, that kind of things. Okay. I would say that, I'm going to come back to this again, that the devices, the instrumentation, the photonics, optical, I don't think that's the bottleneck. That's my personal opinion. If we have the money, we have the resources, there are companies can do it very well for us. Okay, if we just give them the design, that kind of things. See the Apple iPhone, the iPad can be made in China very nicely. Okay, that's a very complicated device, much more so than this. I don't think the devices, as long as we have the right design, the design needs PhDs really, but not the fabrication. What's really going to be the limiting factor in the future is the tracers, is the contrast agent that we can inject into the body, or we can let the patient drink. That would go to where we want it to go, bound to the tumor, and highlight the tumors. And that's going to be a major challenge, require molecular engineering and design. Okay? And I believe that's also where the most value would come from. Okay? And one of the things I think very exciting is this activatable fluorescent probes. The idea is that if you have some of these organic dyes or fluorophores encapsulated into nanoparticles, they will be self-quenching each other. It's energy transfer among themselves, self-quenched. They can circulate in the blood, that they will remain dark or silent. Once they get in the tumor, either activated by lower pH, by hydrolysis, or by enzymes, degradation, you activate the process, okay? So, this is a nanoparticle of indocyanine green. You just encapsulate that. In the nanoparticle state, it's almost completely quenched, okay? When you activate, release that, the signal goes up by about 100-fold, okay? I think this kind of smart tracers or nanoparticles that stays silent, okay? It can be therapeutic drugs as well. When they circulating in the blood, they're not active, but only when they get into your target, especially into the tumor cell, boom, they suddenly become active. I think there's a lot of engineering design will be required for that. Okay? And the other thing is this multifunctional, or people call it theranostic nanoparticles, because it's therapy and diagnostic for integrated imaging and therapy for the same particle. You have a targeting ligand where you would embed both the imaging agent and the therapeutic agent together, so that would give you ability to track where your therapeutic drug would go. Sometimes a nanoparticle therapeutic is not working. You don't know what's the problem, okay? It is often that the therapeutic drug is not being released. They get into the tumor cell, but it's not released to the cytoplasm. They essentially being degraded, okay, inside the organelles. Okay? So you do want some kind of information, see what's the problem. Okay? And one of the things I want to tell you about is this activatable nanoparticles, both for fluorescent imaging and therapy, based on a type of copolymers. I'm not sure you can see this very well. It's a copolymer of this it's polypropylene acetate. So it's a very common polymer structure. Then you, of course, you conjugate that to polyethylene glycol, the PEG, make it a copolymer. And these polymers, because it's amphiphilic, is going to self-assemble into nanomicelles on the order of 20 to 50 nanometers. Okay? The interesting thing is that these kind of particles depends on the hydrophobic and the hydrophilic forces that you engineer into it. It can fall off or assemble very sharply. The standard, okay, that's the transmittance that measures the assembled state. Okay? When the particles are assembled, they become cloudy. I'm going to show you. Okay? When they are dissociated into individual polymers, they're completely transparent. So you can manipulate, control that assembly process with just a 0.1 pH unit. The standard acid-base titration requires almost 1 pH unit. And here you can engineer this by a cooperative effect. Okay, it's a very amazing effect that a tiny change in the pH is going to trigger the entire assembly. Okay, in terms of therapeutic drugs, if the organelle, if the pH inside the tumor cell is just slightly acidic, exactly at the same value, the right value, it's going to trigger the sudden release of the entire therapeutic drug. Okay? And this is a nanoscale phenomenon. In my opinion, it's an emergent behavior. You won't see this on the macro scale. You won't see this on the molecular scale. Only multiple hundreds of the molecule working cooperatively, you start to see this effect. It's like the hemoglobin, there are 4 bonding sites. One site bond, the other side has a higher bonding affinity. Exactly the same effect. Okay? In terms of the entropy, enthalpy, the kinetics, that would have to be another lecture. Hopefully when we publish this, you can read it. But this is a wonderful nanoscale emergent behavior you won't see otherwise. Okay? And let me see, I'd like to just say the pioneering work for this class of material was actually published by Jiming Gao out of UT Southwestern. Okay? And he showed, I quote directly his figure, and you can see that you can engineer some of these nanoparticles to be fluorescent, okay? Exactly at the pH you want. So that's 7.0 or 6.5, okay? And it's going to turn on and off by just 0.1 pH unit. Okay, so here's our own work. Okay, you can see that this is the self-assembled emergent nanoscale behavior. It's cloudy. It's because this all nanoparticles interact. Okay, it's opaque, almost opaque. 7.4, 6.2 pH. Okay, you see that that's 6.2 is completely cloudy. pH 6.1 is becoming almost clear. If you go to 6.0, it's completely clear. Okay? And in terms of the fluorescent, and you know, this is the light scattering. If you look at the fluorescent is actually a drug. It's doxorubicin. How much is being released is that 6.4, you don't have that. It's still encapsulated. And here it's getting released. Okay, so with that, let me go back a little bit with another type. So here is the indocyanine green, which we talk about in nanoparticles. The fluorescence can be completely quenched. One of the good things about indocyanine green is that it's FDA approved for human applications. This is a broad class of agent. It doesn't target any receptor on the tumor. It's only based on the leaky vasculatures, the EPR effect. Okay? So this would be an agent to target a broad range of tumors, but not specifically binding to any receptors. By itself, it's very useful because you can use this for many, many tumors. Okay? And one good thing, again, is FDA approved. When you inject it into the blood, it binds to the albumin immediately to form a 5 to 10 nanometer particle. Then that takes advantage of the enhanced permeability and retention effect. And the bad thing is that it is an old dye. It's being approved for roughly 30, 40 years. So there's a lot of work trying to improve upon this. Another class of dye is based on this is essentially the indocyanine green based on the EPR effect. You know, the leaky vasculatures, no targeting whatsoever, no active targeting. The other class I want to talk about is based on the metabolic activities of the tumor cell. Very much like the glucose, the PET imaging, but in a different way, in an optical imaging way. It starts with a very small chemically modified amino acid by the name of 5-amino levulinic acid, ALA. If you look at this, it's less than 200 Daltons molecular weight. Okay, this thing you can drink, the patient can drink. It's going to get absorbed through the GI through the GI system so quickly. And after drinking this water, you can put the patient on the table, operating table, 1 hour later. The tumor already would be emitting light. Okay, the reason the tumor emitting light is that the tumor needs a lot of nutrients. So this amino acid acting as a nutrient, so the metabolically active tumor has a higher uptake rate for this chemically modified amino acid. It's just the same way as glucose. But more importantly is that when this ALA gets into the tumor cell, it is a cofactor in the biosynthesis of protoporphyrin. Protoporphyrin is the porphyrin without the metal, without the iron. Okay, if you put the iron into protoporphyrin, it becomes hemoglobin. So it's in the path to synthesize blood. Okay, it turns out that if you don't put in the iron, the metal, this this porphyrin, protoporphyrin, is fluorescent in the red. You can excite it in the blue, 405 nanometer. Perfect. That's the blue diode. That's the blue diode laser. I think that's got the Nobel Prize, right? Okay, the 405, just amazing, highly efficient. Then this free porphyrin is going to shift the emission light to about 635 in the red, and the human eye can even see that. Okay? It turned out that most of the tumor cells have an impaired enzyme or lack that enzyme to place the iron into the center of the porphyrin. It turned out that to place iron into this porphyrin is so complicated, it requires the enzyme itself. Okay? A lot of the biological reactions, even though we think it's very simple, it won't happen by itself. It requires a catalyst, enzyme. In this case, the enzyme is called chelatase. It's a chelating enzyme. It's called chelatase, and without that enzyme, then the porphyrin is going to stay fluorescent. And that's one of the reasons that the tumors light up. This is very powerful, being used in brain tumor surgery, especially in Europe. And my colleagues are doing clinical trial trying to get this clinically approved in the US. Okay? And the other thing I would say is that you see that targeting tumors, there are a number of mechanisms. One of them is through the leaky vasculature. That's that's the vasculature. That's a blood vessel in the tumor. It has this little hole. So therefore, the EPR effect by using indocyanine green is based on that. Once it gets into the tumor mass, the pH inside the tumor, in the tumor microenvironment, is always slightly acidic. So by designing the pH-sensitive probes, we can target the acidic tumor environment of the tumor very precisely. Okay? I believe that Jim Singhal at in Dallas, he got a lot of funding from the state of Texas, and he has a company trying to commercialize this thing. Okay, we're also doing this. I think this opens a lot of new opportunities to design these advanced nanoparticles, respond very specifically to particular environment in the tumor. Okay. Another class of nanoparticles I want to talk about, the last class, is our surface-enhanced Raman nanoparticles. I call it SERS nanoparticle tags. Okay? Hopefully you will see why I'm very excited about this. The design of this is that if you have a metallic nanoparticle, for example, gold, colloidal gold, okay, there's a lot of free electrons. That's caused the surface plasma, the plasmonics, that kind of thing. And if you excite the free electrons, okay, with a light beam at the resonance frequency, and then the electromagnetic field at the surface, two polarized, it can be a circle, can be a rod, okay, any shape, but on two opposing surfaces of the particle, you have a much more amplified electromagnetic field. If you happen to have a molecule residing, okay, at that surface, then this molecule is going to experience a much amplified electromagnetic field. Because the scattering signal or spectroscopic signal of the molecule depends on the local, not the bulk, but the local electromagnetic field, and that's the way to concentrate the energy to amplify the spectroscopic signals of that molecule. It's very similar to the lightning rod effect. Okay? You have a point, you can focus the electromagnetic field, get such a degree it can ionize air, that's why you see the glow. It's basically the same thing. Okay? It's the concentration of electromagnetic field at the tip. Okay? And to design this actually requires a lot of time. You have to make this biocompatible, so therefore we use a sulfur modified polyethylene glycol to put a layer of the this biocompatible polymer. And then on the outside of the polymer, we have a peptide or antibody or other molecule that can recognize specific receptors on the tumor cell or the blood vessel. So this ligand on the outside provides the targeting ability. Okay? So you think this is so easy. Okay? If you look at now, it's not so difficult. But actually, the surface enhanced Raman effect, SERS, was first recognized by my old boss, Richard P. Van Dyne, at Northwestern University. Okay, I have to give the credit where the credit is due. Okay? And he first published a paper in 1977. Okay? Because that time, the idea of amplifying the spectroscopic signals by using colloid. That time there's no particle. They don't call nanoparticle. They call it colloid. In chemical engineering, colloid on surfaces is a well-established field. There's no such thing as nanoscience. Right? So he used colloid, okay, and electrochemistry, observed this phenomenon. It was so out of line with the thinking that time. He told me that his manuscript was rejected by several magazines. First, Science rejected, Nature rejected. Then he submitted to the Journal of the American Chemical Society, JACS, rejected. No one would believe it. Then he submitted to analytical chemistry. I see a number of things there, analytical chemistry, rejected. Okay? And finally, he has no choice. He submitted to a Dutch journal, Journal of Electroanalytical Chemistry, which is a Dutch journal. Have you ever read anything in that journal? No, that got published. Okay, and it turned out the phenomena was real, and so therefore his best work is still this work. Okay, and that was 1977. Okay, I just want to inject this historical thing a little bit. Okay, it's interesting. After a while, you look back, science. Sometimes it's quite interesting. 1977. I still contact him. I said, Rick, you're still my old boss. He says, no, I'm not old, but still your boss. I said, it's fine. He's a wonderful scholar. Just very deep. Published a lot of outstanding paper. Well, see, 1977, exactly 20 years later. Okay, 1977. See, I was young one time. Okay, I was young. It just started my faculty appointment at Indiana University with my first graduate student, Stephen Emery. Exactly the same name as Emory University. I asked him, I said, is any connection? He said, no, there's no connection with Emory University. Okay, two of us. That time I insisted I should be the first author. It's because there's some risk in this paper. I don't want to ruin his career. Okay, this is my about 200 paper or so. This is my only first author paper as a faculty member. Okay, it was this one because again it was very risky. We proposed, actually we reported that the enhancement factors, okay, is 10 to the 14th to 10 to the 16th fold. Whereas Van Dyne in 1977 reported is 10 to the 6th fold. 10 to the 6th fold, that upset a lot of people who could not get published anywhere except a Dutch journal. That's 10 to the 6th. 20 years later, we're saying it can be 10 to the 14th, 10 to the 16th. And we published in Science. Okay, I told Steve that whenever it's wrong, forget about his PhD or my tenure. We just go to France to join the cold fusion guys. That time, yeah. We found that we give explanation. Actually, we have this data. See, I want you. This is historical. If I think about this, I feel very happy. Still happy. You see, that was submitted 1996, November 1st. Accepted December 1996. The quickest acceptance I ever seen. Okay? And it was accepted without revision. I tried to add a little bit. They said, no, we have to publish this. Because the two reviewers, actually three reviewers, agreed with each other, this is such a wonderful work. We don't know it's true or not. But the scientific, it really says that, okay? The scientific, but however, you must let the scientific community to evaluate, to judge it. Because we had this data for a year. I just would not dare publish it. I asked Stephen Emery to show this is wrong, to show there's something wrong with it. So he spent the whole year almost in the lab, couldn't prove that we were wrong. Okay, so then we got published. Okay, and then just a year later, Louis Bruce. Okay, let me find where's Louis Bruce. I want to show his picture. Oh, here, Louis Bruce. That time he quit his Bell Labs job because the Bell Lab, they missed the internet, right? They missed the wireless. Still based on their old telephone, they cannot compete anymore. They're going to lay off some of these people, and he started his faculty appointment at Columbia University. He was looking for something to do. Then he found our paper, and he was the first one, 2 years later, repeated everything that we did, published his major paper in JACS, Surface Enhanced Raman Spectroscopy of Individual Rhodium 6G, the same molecule on large silver nanocrystals. He shows wonderful results, including the blinking effect, because the light emitted by the particle is no longer continuous. It can on and off, okay? So I got really worried because, Louis Bruce, he has never been wrong, okay? He knows both theory and experiment very deeply. Before this, his main contribution was the quantum dots. He synthesized the first quantum dot and theoretically explained it. And at that time, Aleph Satos and M.G. Borindi, Aleph Satos at Berkeley, M.G. Borindi at MIT, were two of his postdocs. Okay, so for that reason, when the Kavli Prize in nanoscience was first announced, he was the first recipient. If there's going to be a Nobel Prize in quantum dots, quantum nanocrystals, it's not going to be Aleph Satos. Well, I should not say this, but I think it's likely to be Louis Bruce. Okay? So it turned out that he reproduced everything that we did. It's this work that confirmed our results. Then I feel much happier afterward. Okay? And it still takes work to develop this. In 2003, and my student Bill Deering, okay, was with me, and we developed a core cell structure. We can coat the gold nanoparticles with a layer of polymer or with silica, stabilize it in water, and we'll just take one tiny particle out of that. A single particle, we get a very nice spectrum. So it is this kind of work that gave me the confidence we should have no problem in detecting a single cell in the body. Because the signal to noise is absolutely there. It's no problem. Okay, again, it takes a few years more. In about 2008, we developed this finally. This nanostructure is biocompatible. We inject it into the body, and then we inject through the tail vein. Okay? And then we use a near-infrared 785 nanometer laser beam shine on the tumor, and we're able to pick up the SIR, surface enhanced Raman signals, from the nanoparticles that bound to the tumor. Okay? So we published this in Nature Biotechnology 2008. This is really the first paper showing that this surface enhanced Raman nanoparticles can work inside the bodies. Sometimes, if you look back, you'll say it would be obviously going to be that way. But even before that, before 2008, there was a mental block. No one would dare to inject these surface-enhanced nanoparticles into live animals. I don't know why, okay? Just, we tried to do it. Of course, it didn't work at first, okay? Because you have to play with the coatings. But after we learned how to play with the coatings, it worked immediately. Okay? We detect beautiful signals out of the particles bound to the tumor. So after we publish this, everybody can do it now. Everybody inject particles to get beautiful signals. But why they did not do it before us? There's a mental block. So sometimes you have to think about it. Sometimes it's not so difficult. You just have to pass that psychological block to do it. Okay? And now we have even moved these particles for image-guided or for spectroscopy-guided surgery. See that we inject particles into the tail vein, and that's a tumor there. Okay? We're trying to locate the boundary by surface-enhanced Raman spectroscopy. That's the handheld spectroscopic pain, no problem. Okay? And we found that most of the particles, because are fairly large, about 80 nanometers or so, they're mainly accumulated at the boundary, at the margins of the tumor. Okay, that's excellent for image-guided surgery, but it's not good for nanoparticle therapy. If we look at the tumor center, see that's the line here, the green, that's the center, we see no particles. So again, in terms of imaging and image-guided surgery, it's a little bit easier as long as you can define the tumor margin, the boundary, you will be fine. But for therapeutics, you really have to penetrate the tumor. And here clearly shows for these surge nanoparticles, because they are too big, they cannot get into the tumor interior. Okay? So if you want this one to carry a drug, it will not be effective. So we know now, most people agree, for cancer therapeutics, you have to reduce the particle size for deeper penetration. And then we very quickly we move to dogs. Okay, this is not using the surge particle anymore. This is using the indocyanine green complex with albumin. You see that this is a mid-sized dog. This is the lung. That's a tumor. We have our agent. See that? That's the optical imaging agent. It's strongly correlated with the tumor. Okay? And after that, this is another way showing the dogs this naturally occurring lung tumor in large animals. We consider dogs are large animals, but other people, when they hear large animals, they think about horses and cows. No, we tell them that in Georgia, we consider large animal dogs are large animals. In Illinois, you have to deal with horses. Okay. And you can see it's much larger than mice. Okay, see that's the chest open, everything. Okay, so we are using naturally occurring tumors. I should say that mice, okay, these kind of xenograft models in mice, excellent for papers, publishing papers using mice models, perfect. But they have very little relevance to the human disease. We can routinely cure tumors in mice by using nanoparticle drugs, but these drugs would have no effect in humans. Okay? And the animals, dogs, with naturally occurring tumors is a much better model, but a lot more expensive. Think about this, much bigger, much more expensive. But this is something that we have to do. So with this kind of data, we were confident just 2 years ago to move into human trials. Okay, here shows that we can define the tumor very well by using optical imaging. We know exactly where the margin is. Okay, and then we moved into clinical trial. We have 2 clinical trials. One is at Upenn, University of Pennsylvania. The thoracic surgeon is Dr. Singhal, and he's leading the effort in the lung cancer. And here you can see that by CAT scan, and that's a tumor. By PET imaging, that's a tumor. And this is the bright field under the room light. You see a little bit, and the fluorescence here is correlated. Again, for this clinical trial, we cannot use the surge particle anymore. We have to go back to the indocyanine green complex with albumin, because that's the only thing available, approved by the FDA for us to use. The other type of tumor here is also in the chest. That's the one, and it light up very well. And again, another tumor module that's here. It's correlated with the optical data. Okay. So I want to show you two cases. You see that this is an actual human case. It's a massive tumor of the lung. Okay. This is the inflated. The lung, you can inflate it, or you can collapse it. It depends whether you pump air into it or you let the air escape. So this case is with the air. You can see that it's very full. And in situ, just in the test, in the chest, you do imaging. It's a massive tumor everywhere, the signal. Okay. And if you take a piece of the lung out from the body, you collapse it. It's like that. Then you can image that again. It's there. So for this kind of massive, you don't need fluorescence imaging to locate the tumor. It's so obvious. Okay. However, another case here, it's only some residue things. See, that's the in situ fluorescence. Only a few residue spots of tumor. You do need the optical signals to locate it. Okay, you can take that out. It's mostly normal. Just a few tiny spots are due to tumor. So this is where the case that our technology is going to save patient lives. Okay. And this is open surgery. It's really big open in the chest. It's very traumatic. It's a lot of risk involved. In the future, we're trying to work on is robotic surgery and also minimally invasive surgery. Okay, by using endoscopy or robotics with image guidance, because now the surgeons are pretty good with their hands. That's really what they're paid for. Okay, they have a good pair of hands. They can feel things very well. Plus, their hands don't shake. If you shake, it's a big problem. Okay? But when you do this minimally invasive surgery, you're not going to cut the chest. What you do is open 3 holes between the ribs. You put your instrumentation into it. There's no way you can touch it anymore. So the guidance, the instrumentation, okay, the imagings become even more important in this kind of minimally invasive surgery. Okay, so I think the need for technology in terms of medical application is really broad. Okay? So this is some of the things we're trying to do, and we already start a clinical trial at Upenn. Now going to start. We want to enroll 10 patients for minimally invasive surgery like this. Okay? And this is already approved by the NIH. They're very happy to see us to do it. Okay? And the surgical room is more like this. Okay? Normally, a lead physician have 2 fellows. Okay, work on it. See, these are the 3 holes. Okay? So this is the contrast enhanced image guided cancer surgery under minimally invasive conditions. Okay? So these kind of operations are also very good for the hospital because they generate a lot of revenue. Okay? You see, this is a very expensive procedure. They do it fast. So lastly, I want to say that the miniaturization of the devices. What we want to do eventually is to have a very tiny devices, not much bigger than a millimeter or so, which can be inserted into the channels in robots, in endoscopes. Okay, and also we want to deal with the pediatric, the children's, small babies. So recently we've been able to miniaturize the devices, the entire thing, to about 0.2 millimeter, 200 microns. Okay, almost the size of thick hair. Our thick hair is about 100 micron. Okay, you can insert into these kind of endoscopes. Okay, so let me just conclude that the device development, there are two parts. I think is no problem, as long as you have the money. Okay, but the contrast agent is going to be a frontier, going to be continue to be a frontier in terms of developing optical or other agent that can be injected. So currently, the indocyanine green is FDA approved. That's a broad agent without any specific targeting. In a way, it's good because no matter what kind of tumor, you can always use it. Otherwise, it's not so good because it really doesn't target any specific receptors of the tumor. And the ALA is pretty good. It's approved in Europe, but not in the US. Hopefully, that can be approved in the US soon. And the surge particles offer ultra-high sensitivity and specificity. For cutting-edge research is perfect. We're trying to move that eventually into clinical applications. The activatable, or I call the SMART, these nanoparticles, with cooperative emergent behavior, I think is very worthwhile. And lastly, the cocktail, the combinatorial tracers. Okay? Multiple of these things who can target different things would be important too. And the work is really being supported by a number of things, mainly through the NIH. We had for a while the NCI Center of Cancer Nanotechnology Excellence. I think here you have the training grant. We have the research grant. Our research grant has a training part as well. Okay? And also like to acknowledge the NIH for a bioengineering partnership. And most recently, we have the NIH Director's Transformative Research Award. The key personnel include Dr. Singhal. He's a thoracic surgeon at Upenn. Andrew Young is a pathologist. James Provenzali he's a radiologist, and Kostas Hadjipanayas is the brain tumor surgeon, which part I did not talk about. Lili Yan is an oncologist, and Dongxing is an oncologist. And Mei Wen is actually my wife for quite some time. We met 1990, even a long time. She's a computer expert doing bioinformatics. So she put all of the software together. Okay, I cannot even write a single code of software. I don't even know how to do it in BASIC anymore. Okay, but obviously they can do it. Okay, she can put together professional level packages of apps, that kind of things. Okay? And Fadl Curry is our chair of medical oncology, and so here's just a few people we've been working on. And lastly, thank you for the invitation. It's been really my pleasure, and certainly happy to answer any questions.
Thank you.